I would like to introduce Dr. Wenyu Huang. Dr. Huang is currently an associate professor at the Division of Endocrinology, Metabolism, and Molecular Medicine, co-director of the Comprehensive Metabolic Core and Core Lab Director of the Clinical Research Unit at Northwestern University Feinberg School of Medicine. Dr. Huang has extensive expertise in clinical endocrinology, especially in the area of pituitary and adrenal disorders. His clinical research interest lies in the development of new, novel treatments for rare diseases, including acromegaly, Cushing's disease, growth hormone deficiency, congenital adrenal hyperplasia, etc. As co-director of the Comprehensive Metabolic Core and Core Lab Director of the Clinic Research Unit at Northwestern University Feinberg School of Medicine, Dr. Huang has dedicated and supervised tremendous effort in expanding the metabolic research at Northwestern University. Dr. Huang is also a member of the professional societies, including the Endocrine Society, Pituitary Society, etc. Dr. Huang has published extensively in top-tier journals, including JAMA and Journal of Clinical Investigation. And I have to say, I have worked with him for years, and it has been an absolute pleasure. I truly believe that he is helping forward the science of acromegaly, and he truly is an asset to acromegaly all around. And with that, I will introduce him up, and I will do his slides. There we go. Thank you.
Thank you, Jill, for the nice introduction. And good morning and welcome everyone to this. I think it's a big family here. You know, it's truly an honor to speak in front of my patients, my new friends here, and also their supporting groups here. It is, as I said, I can't speak enough for this community. And again, I would like to thank Jill and the acromegaly community members to put up this event locally and nationally. I think it actually helps us to understand acromegaly and help to advance our understanding of acromegaly as well. So over the next 60 minutes or so, I'm going to give a brief view of acromegaly. It's by no means comprehensive because, as you know, there's so many unknowns about acromegaly, and there's so many unmet needs of acromegaly. There's no way anyone can cover that in about 60 minutes. But I think we can start with some basics, and then we can go forward with more of the unknowns. Hopefully we can solve those unknowns in the near future. So without further ado, and also after the 60-minute presentation, there will be a 30-minute Q&A so we can exchange our ideas. All right, these are my disclosures. All right, so these are the topics I'll be covered in the talk, which include physiology of growth hormone. This is how I do my presentation. Usually I start with physiology. So understanding physiology is very important for us to understand diseases. And then we'll talk about epidemiology about acromegaly, clinical manifestations, including symptoms and signs, and then diagnosis and current treatment options for acromegaly, some treatment options which are under investigation at this point, and lastly, we're going to talk about comorbidities of acromegaly. Right, so this is a little bit about physiology, as you can see here. So, I said the whole thing starts with the hypothalamus, right? The hypothalamus is a very teeny tiny place in the center of our brain, and then that secretes a couple of hormones. And in regard to growth hormone, it secretes two hormones. One is called GHRH, stands for growth hormone releasing hormone, and the other called somatostatin. So one of them is stimulating the pituitary to produce growth hormone, and the other one is inhibiting the pituitary to produce growth hormone. And then the growth hormone then travels and goes to the liver and bones mostly, and to produce something we're all familiar with, which is called IGF-1. Now there is, as the beauty of the endocrine system, there's always some what we call a negative feedback system, meaning the IGF-1 goes back to the hypothalamus or the pituitary to suppress the expression of both GHRH and also growth hormone as well. And there's some other factors which are listed only here about stress, but there are many other factors like ghrelin that are also affecting this process as well. Now, as I mentioned earlier, our nervous system is actually quite complicated. It's not only about the hormonal, there are many other factors that also control the growth hormone release. On the left side, you see the sleep-wake cycle. As we all know, that growth hormone is not secreted flat throughout the day. Actually, it's actually high at night. And then also importantly, the growth hormone is secreted in the manner of pulsatile. You can see it goes like this throughout the day. And then the other thing that also play a big role in our daily life, sometimes we even forgot about this, is something called circadian rhythm. We do have a teeny tiny gland place called SCN, it's called suprachiasmatic nuclei. It's a very teeny tiny gland that's preserved across many species, at least in the mammals, and that actually controls our daily rhythm. So we have the diurnal rhythm. And then with all the input, the hypothalamus basically incorporate all the symptoms, all the signals from all over the other places, like mentioned here, and then affecting many hormones, growth hormone being one of them. You'll be surprised to see, some of them realize that there are other hormones that we're dealing with, prolactin, thyroid hormone, ACTH that drive the cortisol production, and LH, FSH that drive the ovaries and the gonad, the testicle to produce estrogen, progesterone, and testosterone. So this is a very well-regulated group of neurons and also neural pathways that actually in control our daily physiology. Now, this is just one example of the hormones I mentioned earlier. As you can see here, I put growth hormone here. You can see it's nicely pulsatile growth hormone secretion. And then this is indicate this is the night. Okay, you can see there's a bigger peak at night of growth hormone. But growth hormone is not alone. You can see some other hormones here and there. They also demonstrate their own very unique circadian pattern, and many of them actually also pulsatile as well. So, all right, so this is a little bit about physiology. So as I mentioned earlier, growth hormone is pulsatile release, right? So if you have a random growth hormone track, you could either catch the peak or the bottom. That's why sometimes we actually use IGF-1 as a marker for growth hormone activity, because IGF-1 level, if you look at it, is actually more stable over time. Now, talking just about acromegaly, as you all know, is a rare disease. If you're talking about, we usually talk about two things when we talk about epidemiology. And number one is prevalence, which means how many existing cases do we have? And then different reports have different numbers, but in the ballpark of 3 to about 14 per 100,000 people. That was the data from 2001 and 2013. Now, if we're looking at new cases each year, you can see just about somewhere about 0.2 to 1 per 100,000 people. That was data from 1955 to 2013. So it definitely is a rare disease, if you think that way. And then, unfortunately, we all know that there is a delay usually in terms of diagnosis, and mostly, people have the diagnosis delayed. Many of you are manifesto for that is about 5 to 6 years. I think this is one part of the unmet needs. We should actually do a better job of trying to diagnose and recognize this pattern so that we can diagnose our patient earlier. And also, if you see, look at the whole population of patients with acromegaly, you see women are slightly more than men. And then, and also women tend to have later diagnosis than men. So it's about a few years earlier men are diagnosed than women. So these are the epidemiological data that we have known. Okay, so these are probably very familiar to you. These are the symptoms of acromegaly we pay much attention to before the diagnosis, at the time of the diagnosis, and during our treatment. And also after surgery, we ask about those symptoms as well. So the most common ones that we see here is fatigue, excessive sweating, joint pain, which can involve many joints, small and big, and small tissue swelling, hands and feet, even vocal cord. People have sleep apnea. And snoring, that's part of sleep apnea symptoms. And neuropathy, many of the patients have carpal tunnel syndrome. That's one of the reasons I ask a lot of my patients, during clinic hours, whether you have any tingling, numbness of fingers. The neuropathy can be presented another way because with growth of the bone, and some of the nerves can be trapped and pinched. So then there's other nerves can also be involved as well. And acrofog, or we call it forgetfulness or short-term memory loss. Those are the symptoms many patients experience as well. Now, these are probably a result of too much growth hormone IGF-1, but also we had to think of other problems. One is headache. The headache can be a tumor effect. If you have a bigger tumor, you can have headache, but there are some patients who actually the headache is independent of the tumor, and their tumors are resected, removed, and then they don't have much tumor left in the pituitary gland place, but they still have headache. These are another area we need to put focus on and research at. And then visual disturbance that happens sometime with the patient, especially when they have bigger tumors. So we separate of those symptoms and signs based on whether or not they're directly related to IGF-1 growth hormone oversecretion, or if patients have big tumors. And then don't forget about the tumor itself, because if the tumor is big, or as a result of surgery or radiation, patient may have deficiency of other pituitary gland. Remember, pituitary in itself, what we call the front part of the pituitary, that actually secretes 6 different hormones, and growth hormone is only just one of them. So the doctors and you also the doctors may check, and you may experience some symptoms of low pituitary hormones, such as low thyroid hormone, low testosterone, stop having menstruations, and things like that. And some women even can have high prolactin due to a variety of reasons. And then in some women, we see they have lactation, even if they're not pregnant. Now, you can see that this is just an overview of the clinical features of acromegaly, and you can see the years of diagnosis, about 40-some years old, and and there's a high prevalence of symptoms, and with all the symptoms I mentioned earlier. Now, what about the symptoms? It's the signs of acromegaly. I remember one of my patients, he was actually diagnosed, he was found or suspicious to have that disease, and because one of the family members who happened to be a physician realized that his facial features have changed over time. So you can see this lady on the top right, and over years, she has developed the typical features of the face over years. And also, you can look at the bottom right, and with the hands change over time as well. This is on the left side is normal size, and the right side is a patient with acromegaly. And then on the left lower corner, this is not very common, but can be very telling if the patient develops this kind of features on the scalp. So acromegaly can come in different shapes, but these are the most commonly that people recognize it, and some even for the physicians. I chatted with some of our patients here, and some of them were suspicious to have the disease based on those features. So we talk about physiology. We also talk about pathophysiology and symptom and signs. So the next thing we talk about how we diagnose acromegaly, right? So there'll be 2 parts usually that we're dealing with. Number 1 is biochemical evaluation, and number 2 is imaging. Now, we tend to do a single level of growth hormone, but as I mentioned earlier, since growth hormone is released in a pulsatile manner, just one single level is not going to tell us the whole story. And luckily, we have a IGF-1 level which are more stable throughout the day. So most of patients at the time, almost all patients at the time of the diagnosis, they have elevated level of IGF-1. But also remember that the IGF-1 and growth hormone, they change. They change between genders, they also change before age. If you're aging, with the time of aging, you also with the growth hormone level going down, and also IGF-1 level as well. Pregnancy also can change growth hormone IGF-1 level. So there is actually a very intricate relationship between the external factor that how they change growth hormone IGF-1. They sometimes don't move in the same direction. This is something we're trying to understand more about. Most of you probably at the time of the diagnosis also gone through something called oral glucose tolerance test. So this is the test where you are asked to ingest about 75 grams of glucose, and then you were taking blood every 30 minutes for 2 hours and looking for suppression of growth hormone. And so the Endocrine Society guideline in 2014 listed it as the growth hormone less than 1 nanogram per ml as a criteria, but that was using the old assay. Now with the higher sensitivity assay, and I think most of the experts are using the level of 0.4 nanogram ml as a cutoff for diagnosis of acromegaly. However, that really depends on what assay that your doctors are using to make the diagnosis, because there's so many out there, commercially available assays that have probably have different characteristics and diagnosis criteria for this oral glucose tolerance test. And then don't forget prolactin. So some tumors actually, will be called, these are the tumors, so look at progenitor cells that produce both prolactin and growth hormone. So not only growth hormone is oversecreted, and prolactin can be also oversecreted. And there's another mechanism we call stalk effect, meaning the tumor is big, is actually go to a place or near a place we call the pituitary stalk, and the compression of that stalk can also cause high prolactin, but those high prolactin not from the tumor, it's actually from the normal prolactin producing cells. So, so these are things to keep in mind. And then also very important, as I mentioned earlier, the anterior pituitary, or the front part of the pituitary, they actually produce and secrete 6 different hormones, right? So we'll only mention 2 of them. And so if patients have bigger tumors, I definitely want to also know, are there other tumors, are there other hormones that are deficient because of the tumor? So very important to know the whole picture of the pituitary. Imaging-wise, no doubt MRI is what we call the standard. Usually we do with and without contrast. The reason we do with contrast is because the normal pituitary enhanced different than the tumor. So, you know, with the MRI, we're trying to achieve several goals. Where is the tumor? How big is the tumor? And what the relationship of the tumor to the adjacent structures. For example, the optic chiasm, you're probably familiar with the term, is what I call the eye nerve that's right above the pituitary gland. And also about the cavernous sinus, which is just next to the pituitary gland, which also harbors the nerve that controls our eye movement. And also the IC is intracarotid artery, which is also very important, as you know, that supplies the main blood to our brain. And then unfortunately, at the time of the diagnosis, you know, 2/3 of the tumors are macroadenoma. I'm going to explain to you what is that. And then if there is a big tumor, visual field test, probably some of you already have it with your physicians, is a need to be checked with the ophthalmologist. So this is a structure you can see if you're reviewing the image with your endocrinologist or neurosurgeon. You can see this is where the pituitary gland should be. And the pituitary, as I said, it has 2 parts. One is the front, we call it anterior, and there's a part called posterior pituitary. And then this is what I call infundibulum. This is the pituitary stalk. This is optic chiasm, where the eye nerve, and this is a small place called hypothalamus that controls many different things in addition to the pituitary. Now, as I mentioned earlier, this is normal pituitary. This is a different view because the first one is looking at the patient this way. Now this is more like front view of the pituitary. You can see this is where the pituitary gland is. The optic chiasm is on top, the stalk in the middle. Look, I call it a little neck connecting the hypothalamus with the pituitary gland. And so you can see that when they receive contrast, the pituitary gland is brighter. You can see the difference? Now tumor usually, especially small tumor, does not have that. They usually is enhanced less. I'll show you a picture. All right, so you can basically classify the tumor in different ways. Number one, the most common way we use to define them by their size, right? So if the tumor is less than 1 centimeter, we call it macroadenoma. If it's more than, or equal to 1 centimeter, we call macroadenoma. And then for those who are much bigger, with a 4 centimeter, we call them giant macroadenoma. And or you can also define them by their functionality, right? So you can say the tumor is there but not doing anything, or not over-secreting any hormones. That's about 1/3 of the tumor. We call non-functioning adenoma. And also there are functioning adenoma, most common is prolactin-producing tumors, but also we here, relevant to this talk, is growth hormone-producing tumors, which is about 1/10 of all the tumors. You can actually, when you define a tumor, you can say, hey, this is a prolactin or growth hormone producing macroadenoma, microadenoma. So in that way, you can basically use both definitions. You can see this is a macroadenoma because you see this is the normal gland and this is a very small tumor. You see the tumor looks a little darker than the rest of the pituitary gland. And next one, you see a little bigger tumor here, which are bigger than the one we saw. And also you can see this tumor. So they look, this tumor now is in the middle, but also you can see that actually these two black dots are the intracardiac artery, the tumor kind of wrapping around it, or at least next to it. So this is what we envision of the cavernous sinus. And unfortunately, there are some patients that were diagnosed so late, and this is a huge tumor. We call joint adenoma. So yeah, so now after the biochemical diagnosis and also the imaging confirm the diagnosis of acromegaly and also confirm the functionality of the rest of the pituitary gland. Now we can talk about treatment of acromegaly. So there actually, I like the slides because it listed all the things we need to keep focusing on when we're treating patients with acromegaly. So the first one is very easy to understand. So oh, sorry. All right, so reduce IGF-1 level to their age and gender corrected normal. So this is our biochemical goal. And also we need to control growth hormone hypercirculation. And then as you all know, patients have symptoms. So not only we try to achieve biochemical goal, we also want to hopefully achieve the goal to relieve the symptoms. And I think the best way to resolve the symptom, and we can. And also, don't forget the tumor. We pay attention to the biochemical control and also symptomatic control. But remember, some people, they still have a residual tumor in the brain. So we need to follow up on the tumor size, and hopefully the effective therapy will either remove or reduce tumor. And also, as I mentioned earlier, bigger tumor can have vision defect. So one of the treatment goals is to try to correct that and improve that. And then, try to preserve pituitary function or correct pituitary hypofunction if there is one, and then also correct some hormone deficits I mentioned earlier. So this is a whole slew of goals we're trying to achieve as a team, both the physician and the patient. So this listed a view of the current therapy that we have. So this is the pituitary gland, as I mentioned earlier, that secretes growth hormone, goes to the liver and bone, produces IGF-1. And so the current treatment paradigm is, if you are diagnosed with acromegaly, there is a chance we can do surgery, radiation, or you can use some medical therapy, which we can discuss a little bit more in detail in the next slide. So this is a wire layout algorithm. I'm sorry that some of you can't see here, but basically you see that if you're diagnosed with acromegaly, and so the first thing you should do is to seek out for a surgeon well experienced and try to have surgery. So let's talk about each one of those options. But this is actually a published guideline in 2014 from our journal. If you're interested, I think we can share the slides with you about this treatment algorithm. Now, I'm going to briefly review surgery because I think we have an excellent speaker. Our neurosurgeon, Dr. Asamero, is going to go over the surgery with you, the surgical options with you. So basically what I see in my practice, most of the people have interest in auto surgery. I think a lot of you folks have had that surgery that goes through the nose, go to the sphenoid sinus and reach the tumor and remove the tumor. It depends on the size of the tumor. If the tumor really grows above the sala, I think going this approach may not remove all of it. And then some people rarely need this approach, and then we call transfrontal approach to remove the tumor. So I think our surgeon in the hands of a very experienced surgeon is actually quite good. So if you have a small tumor, you have a likelihood of 3/4 to about almost 90% remission rate after surgery. And a bigger tumor, of course, as you can see, that have a little less chance of getting remission after surgery. And that highly depends on the experience of the surgeon and the center as well. Now, Maria Flestro published a paper about the predictors of surgical failure, and you can see that some of the features, cavernous sinus invasion, that in itself already indicate the tumor is invasive, and it actually adjacent to very important structures of the blood vessels, so it's hard to remove. Wider tumor diameter, meaning the tumor grows outward to the side, and also that's correlates with the cavernous sinus invasion. And also increased preoperative growth hormone concentration, which means the tumor is very active biochemically. Younger age, this is also what I've noticed, that patients with younger age tend to have big tumors and hard to remove. And there's also no consistent association between preoperative IGF-1 level concentration and the postoperative remission. So even if a high IGF-1 level before surgery doesn't mean you can't be cured. So the hope is there. So that's about surgery. And as I said earlier, so the colleagues after me will talk about more about surgery. Radiation therapy. Some of you might have already received radiation. So in the old days, we do conventional. Nowadays, it's rarely used. What you probably have seen is stereotactic radiosurgery or fraction stereotactic radiotherapy, which has to go in multiple fractions here. So these are the commonly used ones here. So I'll focus on the second part because that's the most often used. So usually, stereotactic neurosurgery is cause less radiation to the surrounding tissues because the old way radiation conventional go like this. So everywhere in the path between the source of the radiation and also the pituitary tumor got damaged as well. It's collateral damage to the brain tissue. The ones that are commonly used are gamma knife and linear accelerator and proton therapy and cyberknife illustrated as each one of them. And then they have their own pros and cons. I encourage you to talk with your radiology oncology doctor about what treatment you have in your local place. Now, the first question I think most of you ask, why I'm getting this? What are what we call indications for radiotherapy? You can see that if a patient has persistent and symptomatic excess hormone secretion after surgery and medical therapy, and I think radiation should be considered in a selected group of patients. And it's also commonly used in conjunction with medical therapy because radiation takes some to work. So between the start of the radiation until if the radiation is working, there's a period of time you will need help. And also if primary therapy or surgery, right? So when people have surgery is the surgeon will think the patient have very high risk for surgery. They may not be able to do the surgery or patient may refuse surgery. And in that case, radiation can be considered. And as I mentioned earlier, nowadays, a focus on stereotactic radiosurgery is much more preferred than the old conventional radiotherapy. So what are the outcome of the stereotactic radiotherapy? So you can see there is a definition. There are two definitions here. One is called endocrine remission and the other is called endocrine control. You can see the endocrine remission, meaning that the patient after radiotherapy is controlled without the need for any medical therapy, where the endocrine control means they're controlled with medical therapy. At about the 5-year time, about 43% of patients are able to achieve endocrine remission. Give it a little longer time, there are a few more, there are actually 14% more patients actually get the endocrine remission. But the good news is that endocrine control with the help of medication also help 55% of patients at the 5-year mark and so 70% at 10-year mark. And there's not much data about 5-year tumor control, but in 10 years, if you look at the tumor size, I think radiosurgery is doing a good job of controlling the tumor size. You maybe come upon this, what about the adverse effects of conventional radiosurgery and also stereotactic radiotherapy? The conventional one was the studied most. So up to 80% of patients may develop some form of what we call hypopituitarism. So I listed all the hormones here. The most common hormone that can be lost is actually LH and FSH. Remember, these are reproductive hormones, so reproduction can be affected here. And then the other one that also can be lost is the cortisol promoting hormones and also thyroid hormone promoting hormone as well. So you could have low cortisol and thyroid hormone as a result of radiation. And I'm talking about the conventional, okay? So could be a chance by 20 years, 2% with second brain tumors, strokes increased by twofold, cognitive function, but luckily the cognitive function and encephalomalacia is actually very rare with conventional radiosurgery. Now, what about the one that we're using nowadays with stereotactic radiotherapy? I think the risks should be smaller than the conventional ones. You can see that the new hypopituitarism is smaller, somewhere between 50 and 30% over time. The visual impairment is about 2 to 3%, and the secondary brain tumor over 20 years, the data shows it could be a twofold increase, and stroke rate is about 2.3% over 10 years. The cognitive decline is rare. So relatively safe procedure if it does job to control the tumors. So I'll focus the last part of the talk, focusing on the medical treatment for acromegaly. This again, you saw the slide, but this is actually what I call the target. So when we are using medical therapy, we can target at different places. We can target the pituitary using something called dopamine agonist. Most of the time we're using something called carbamazepine. Or you can target the tumor using a different mechanism we call somatostatin analogs, or SSA. And you can see octreotide, lanreotide, pathology. These are familiar names to most of you. So this is a place where you target here and the pituitary. You can also target the growth hormone receptor. So the growth hormone, as I mentioned earlier, that goes to the liver and bone, produce IGF-1. So what you can do is you can block the action here, as I mentioned here, using this antagonist called pegvisimone that helps to control the IGF-1 level. Our goal, biochemical right now, is have a normal age-adjusted IGF-1 level based on the current guideline. And also, at that guideline, there's new random growth hormone less than 1, but I think with the neuro assay, we could be shooting for 0.4. We're close to that range. I'm going to go over in the next few slides about each one of the medications. So I'll start with the carbamazepine. But first, I would like to say that even though a lot of you are on carbamazepine, this is not FDA approved. We actually use that off-label, and in some patients it can be effective. About 20 to 30% effectiveness in disease control, meaning to control the IGF-1 growth hormone level. Not so much data about the tumor control, but for the IGF-1 growth hormone is effective in about 20% cases. And worth a try in mild cases. Usually I try it if the IGF-1 level is around 1.5 times the upper limit normal, and can be used as a monotherapy in some mild cases mentioned earlier. And also helpful if you can add it to a somatostatin analog as add-on therapy. And this is a medication is usually given twice a week. The dose that we use here is usually higher than we use for prolactinomas. But some patients, they have a hard time remembering doing twice a week, and sometimes I use it once weekly as well. The most common side effect with carbamazepine is what I mentioned here is GI side effects. Nausea is actually the most common ones, headaches or dizziness. So luckily, all these symptoms are usually transient. When you start taking the carbamazepine medications, you may experience those side effects, but usually you give it another, like 2 or 3 weeks, and most of the time, those side effects will go away. However, there's some uncommon side effects that usually happens when the carbamazepine is given in pretty high dose. And we mentioned, here we have cardiac valvular disease and some impulsive behaviors. I do see once in a while of the, especially in impulsive behavior in a few patients when there are high dose of carbamazepine. So this is an oral therapy, as I mentioned earlier. I think it's the niche of this is where you can use that in a very mild disease or as an add-on. Octreotide, LAR, and lanreotide autogel, I put them together because they're the first generation somatostatin analogs. They're both FDA approved for treating this indication. As I mentioned earlier, the main target in this condition will be somatostatin receptor 2, SSTR2. And they're more effective if you look at the data compared to carbamazepine, about 40% effective, could be hitting 45% effective in biochemical control. And in tumor control, look a little bit better, about 40 to 60% to maintain the tumor size over time. It can be combined with other therapy, either which would dual or triple therapy. And usually, as some of you are already on this medication, are usually given about every 4 weeks as injection, but can be stretched out to every 6, even 8 weeks in some patients with lanreotide autogel. And it's especially when the disease is pretty well controlled on the more frequent dosing. If your doctor and you agree, we can try the less frequent dosing. And then the common side effects of this whole class of medication is again focused on the GI tract and also the gallstone. Gallstone can form. So if you develop some symptoms in the upper right quadrant, pain that radiates to the back or the shoulders, let your doctor know. And also those agents, somatostatin analogs, can also affect insulin secretion. So some patients may experience higher sugar, or some patients they may experience lower blood sugar. So if you have diabetes, and I recommend you to pay more attention to your sugar numbers. So report to your doctor if there's anything wrong or different than your baseline. So these are the injections I mentioned earlier. There's also a form of acromegaly which can be given orally. It's FDA approved to treat acromegaly. It's actually it's still the first generation of somatostatin analog, which is, as I mentioned earlier, it is octreotide. Again, the main target is same as injectable, is the type 2 receptor we're dealing with. And in the study, it shows similar efficacy to the first generation injectable somatostatin analog. It is given orally twice a day, and you have to take it an hour before or 2 hours after eating. And the common side effects are similar. I didn't list everything, but similar to the one that we see on the injectables. So this is, I think, how it works. Basically, it's a prodrug in a capsule. What happens is they use the technology to open what we call tight junction. So in our gut, very interesting, we have something called tight junction. We try to prevent things coming through what we call epithelium of the gut. So what happens is, this is a protein without octreotide. It cannot usually go through in a normal situation, but when you use the technology called TPE that opens what we call the tight junction, so the drug can go through the side of the cells and go into the bloodstream. So this is the most recent study that I got the earlier data about the comparison between the injectable and the oral. So you can see the study patients start with the injection, and then they're on the oral capsule. Then the patient are randomized into a oral capsule versus the injection, and then but in a 3-to-2 ratio. And then at the end here was study looking at the primary outcome. As you can see here, at the end, so there are 50 out of 55 patients and 37 of on the injectables. They're able to achieve control at the end of the study. So the adjustable difference in proportion is about 91%. So these are what we call first generation somatostatin analog. This is what we call second generation somatostatin analog. It's called pasireotide. It's also FDA approved to treat acromegaly. It's also approved for Cushing's as well. And the main target is a little different. So it's targeting receptor type 5 and 3, and around 40% effective in disease control and up to 80% in tumor control. Is usually again given as every 4 weeks as injections, and it can be given in patients who are resistant to first generation somatostatin analog. In that case, you can obtain another 20 to 50% control in those cases. Again, the common side effects shared with the first generation are GI side effects and gallstone, but pasireotide does come with a higher risk compared to first generation of causing high blood sugars. And so this slide illustrates the pasireotide versus octreotide. You can see that there's overall, there's post-surgery, and then how it can control the IGF-1 level and growth hormone levels, and in those groups. So overall, pasireotide in this case is a first-generation resistant patient that actually have a better response compared to the first generation. These are selected patients who are not respond to very well to the first generation. And I mentioned earlier, this is what we need to look at because I have some patients who are on the pathology. This is one thing. After I talk with them about the efficacy, this focus of the talk is about worsening glucose. You may expect your sugar numbers to go up after pathology. So you can see here, change the hemoglobin A1C for those who are not familiar with the hemoglobin A1C, basically a marker for the average blood sugar numbers for the past 2 or 3 months. And you can see in the group receiving pathology versus group receiving ultrotide, there's a higher risk, there's higher change. So A1C went up more in patient in all group, either they're diabetic patient or pre-diabetes, non-diabetic patient. And anti-diabetic medication required during that trial, definitely there are more patients in the pathology group versus the ultrotide group. So there are some new paper just about to be published about what are the risk factors of those who do develop what we call hyperglycemia or adverse factor of glycemic control. These are the ones who already have a diagnosis of pre-diabetes or diabetes, where they have high level of A1C and fasting plasma glucose before they start the medication. So if you're one of them, you have diabetes, if you're starting this medication, pay more attention to your sugar. And then we come to pegvisimone. As I mentioned earlier, this is sort of the mechanism of action. So growth hormone have 2 binding sites to the receptor. So a lot of our hormones work in the way they bind to a receptor on the cell surface or inside the cell. So the growth hormone receptor tend to be on the cell membrane. So it's like a hand, but they have 2 places that it binds to growth hormone. There's 1, there's 2. And then, so what pegvisimone does is, just so the set 1 here, the binding out to the growth hormone is a hand. So strongly bind to that, but then actually prevent the real growth hormone to bind to the receptor. And so, but when pegvisimone binds to growth hormone receptor, and usually, but not usually, so when growth hormone bind to 1 and 2, so the signaling pathway goes this. Now with pegvisimone, it does bind, but there's no signaling pathway going through. Basically lock the door. So that's how this medication is helping patients try to control their IGF-1 level. So again, it's FDA approved to treat acromegaly. I mentioned earlier, the target is the growth hormone receptor. Around 60 to 90% effect in disease control, and it can be used as a first-line monotherapy according to the new guideline. It can be switched from somatostatin analog, can be added to somatostatin analog, especially if large tumor residue. And it given as a daily injection. However, it can be given less frequently if combined with other therapy, and the disease can be well controlled in that scenario. And one thing the doctor should be looking for is abnormal liver function that happens around 3% of patients, and also monitor MRI for tumor growth as necessary. So actually, most of the tumor, according to the Acro study that study the pegvisimone in real life, doesn't show much of a risk of tumor growth. So most of the cases, the tumor is unstable in size. So these are, we talk about a little bit about all this as a monotherapy, but oftentimes we can use combination therapy as well. So the most commonly used ones, you can combine the somatostatin analog with pegvisimone. That's the most commonly used. Or if some patient on somatostatin analog and their IGF-1 just a teeny tiny above upper limit normal, I can also add carbamazepine, try to bring back. But remember, these are using different targets, right? So as I mentioned earlier, these are targeting the somatostatin receptor, these are targeting the growth hormone receptor, and these are targeting the dopamine D2 receptors. You can also use carbamazepine and pegvisimone, which is not very common, but theoretically you can do that. And also, I know in some patients they actually need triple therapy as a combination of somatostatin analog, pegvisimone, and also carbamazepine. So if you're not controlled, triple therapy isn't an option. Lastly, which is not very commonly used, you can use estrogen or something called SERM, selective estrogen receptor modulator. I sometimes use clomiphene. So these are, you can use that. There's some efficacy, but it's not really recommended in the guideline to use. But in some patients, for example, women needing for HRT, hormone replacement therapy, maybe adding estrogen can help with IGF-1 controls. For men who have low testosterone, especially young men, we try to preserve their fertility without giving them testosterone. We can try clomiphene, which actually may have 2 purposes. One is it may help to control the acromegaly, and second, may help to wake up their reproductive system, so preserving both testosterone production and also sperm production. But as I said, these are very selected cases based on the experience of your treating physician. And then the other part I think we're not usually talk about is actually pathology. I incorporate that very heavily in my practice because I think some of you see me and I was requiring pathology slides from your previous doctor, and because I want to understand what the tumor looks like, what the behavior of the tumor that can be discovered on the pathology. Just for you, this is something called HE staining. And so basically, this is a very common stain for every pathologist knows. But this is growth hormone staining. Basically, those dots are highlighting the tumor cells that are secreting growth hormone. And there's also something called cytokeratin staining. The reason we do that, because we realize that when we stain for them, you can see this is very densely granulated, this is sparsely granulated. That actually has clinical implications. So most of the patients with densely granulated tumor, they tend to respond favorably to the first generation somatostatin analog. Now, not so much so for sparsely granulated tumor, and so these can be effective treated by this first generation, but sometimes much bigger proportion need a different agent to try to control. So as I said, I try to incorporate that into the system and in my decision making in terms of treatment. And I want to emphasize here, as you see here, this is the 2017 guideline in terms of the pathology for pituitary tumor. You can see that it listed the likelihood of recurrence of pituitary neuroendocrine tumor, and some of them are listed as high probability. And you can see here, one of them is actually sparsely granulated growth hormone tumor. So, pay attention to those kind of tumor. And also, those kind of tumor tend to have different features on the MRI as well. So a lot of times, your surgeon and I may look at the MRI, look at something called T2 signals to see, and because sometimes those signals on the MRI can give out this information or entirely related to this information. So if you're seeing me, you wouldn't be surprised if I ask more slides. So got our neuropathology to read it again. A brief summary about the medical treatment of acromegaly. We mentioned about somatostatin analogs, the 2 generations. That remains the mainstay of medical treatment for acromegaly. They use the one that we use listed here, the untreated LVR, the lanreotide autogel, the pasireotide, and also oral octreotide capsule. Carbamazepine is off-label use, but worth a try in mild cases. Can also help with added as add-on therapy to the somatostatin analogs. Pegvisimone can be used as first-line monotherapy, can also as a switch from somatostatin analog is now working, or can use as an add-on, because you can choose all these options. As I mentioned earlier, you can even do a triple therapy if you want to, if you need to. I want to briefly review what are the pipelines, and hopefully over the next month and years we can hear more from them. So one is a small non-peptide molecule, somatostatin analog, it's called Twistedin, from Crinetics. And there's also Ultratide subcutaneous injection, because you remember that the Ultratide IOR is intramuscular, and then the lanreotide is deep sub-Q. This is called CAM2129. And there's another one that's being studied is Dubio 4126. It's a 3 months Ultratide injection. They are doing the phase 1B trial now. So I'm going to try to review what we have here. So the Twistedin, as I mentioned, is oral, once daily, non-peptide, because remember the somatostatin analogs are all peptide hormones. This is non-peptide hormones. So they have that one phase 2 trial was called Acrobat Advanced, single-arm open-label extension trial. You can see this is the weeks and leading to the washout, the patient on injection, the washout, and then giving the Twistedin. The numbers are pretty controlled over time. So these are actually, the advance is an extension of something called Acrobat Edge, which you enroll patient with IGF-1 more than or higher than 1 times upper limb normal, and Acrobat Evolved, IGF-1 less, so you could do 1 times upper limb normal. So they combined, and then they make the advanced trials. And I know that Crinetics is probably going to release their phase 3 trial result in the next couple of months, so stay tuned. And this is a CAM2029, is as mentioned earlier, is subcutaneous injection you can do at home, as monthly injections. These are listed different transitions. So the patient are on the intramuscular injection of the LVR, either at 10, 20, and 30, then they switch to the 10 milligram every 2 weeks or 20 milligram every 4 weeks injections of this medication. So the line here indicates the time of the switch. And for example, the top left, I believe these are the groups that actually switched on A. You can see that previous injections here, the switch, the IGF-1 levels are relatively well controlled. These are individual patients. And then just off the, I think right after the Endocrine Society meeting, so they didn't publish yet, but this is from their website, about their 24-week phase 3 randomized double-blind placebo-controlled trial. You see all those terms, which means the patients are randomized into placebo. Some of them will receive placebo, some of them will receive the active drug. Double-blind means the physicians, the investigator, and the patients do not know which arm they're on. So 72 patients on stable regimen with ultralight IR or lanreotide autogel for 3 months are enrolled into the study. And before their enrollment, their IGF-1 level has to be well controlled. And they're randomized to a 2-to-1 ratio to treatment with ultralight subcutaneous depot or placebo. And then on the left side, they report the primary outcome. And so the normalization is of the IGF-1 less or equal to 1 upper limb normal at week 22 and 24 is considered their primary outcome. So about 72% of the patients on this medication versus all were switched placebo, 37.5% on placebo able to achieve the primary outcome. So the data is not published in the journal yet. I hope that we'll see some data, formal data out of this trial. And all right, so we focus on just the acromegaly itself, right? We talk about tumor control, we talk about the biochemical control, medication, surgery, radiation. But as you know, acromegaly doesn't come along. It comes with some comorbidities. So, and part of our job as a physician and patient team is to try to address those concerns as well. Now you can see the growth hormone receptor is basically in a lot of places, right? So it's not only, it comes from the brain, but also pituitary gland affecting the heart, some cerebrovascular events that can happen, headache as a result of the tumor, and also as a result of the biochemical factors. With the heart, some people may have hypertension, cardiomyopathy, valvular disease. As I mentioned earlier, their patient, because of the tumor, radiation, or surgery, they could have a low hypogonadism, which means low reproduction in men. Most of that's low testosterone in women. That could mean they have low estrogen or stop menstruating, arthritis. Patients have that. Also colon polyps, glucose intolerance I mentioned earlier. There's also could have some respiratory complication and sleep apnea as well. So not only we focus on the biochemical tumor, we also have to look at the human body as a whole. So I'm just selected some of the most commonly comorbidities we need to deal with that oftentimes involve other subspecialty doctors. For example, a lot of times if there is anything wrong with the heart, we oftentimes need cardiologists to help us. So as I mentioned earlier, the most common ones we see is hypertension, hypertrophic cardiomyopathy, meaning the heart have issues, heart are bigger and thicker, and could have heart valve problems, could also have arrhythmia. So the current guideline put out in 2020 by the Acromegaly group, the blood pressure should be measured at baseline every 6 months or upon change of any hypertensive medications. Make sure that your blood pressure is well controlled. And oftentimes you need echocardiogram, look at the structure of the heart, and also you need electrocardiogram or EKG or ECG, and to look at the rhythm of the heart. So these are important for you to have. And also, if there is any abnormality, the endocrinologist can refer you to see a cardiologist to address directly of these concerns. There's also pulmonary comorbidities as well. So as you probably, most of you experience, you may snore, your partner may say you're snoring. So this could be a sign of obstructive sleep apnea, or OSA. And I also refer my patient to for the sleep medicine doctors get a sleep study. Though I always want to get them, to have a baseline or before surgery if OIC is suspected. That also help the anesthesiologist to know about your physiology in your throat, so help them during the anesthesia, help to make it more smooth and safer. So sometimes I refer them to pulmonology, sometimes I refer them to sleep medicine to deal with pulmonary comorbidities. And there's also a concern with acromegaly about dealing with tumors. So we know there is a relationship between acromegaly with colon cancer. So at least we should get colonoscopy every 10 years. However, though, if such thing happens, if the IgG1 remains elevated, or the first colonoscopy is abnormal, there's a family history of colon cancer, so of course the colonoscopy needs to be done more frequent. I tend to have a baseline colonoscopy for my patient, even though they're young, to get a baseline idea of where they are, and then I work with the gastroenterologist and try to understand the frequency needed for their future colonoscopy screening. And also, we know that a thyroid tumor can be found, more often found in patients with acromegaly. So if your doctor feels your thyroid and there's a nodule there, then I highly recommend it, and you got an ultrasound. Sometime maybe or may not be a nodule there. If there is a nodule, there's a guideline, and we follow from the American Thyroid Association or American Radiology Association, try to understand, some of them may need a biopsy, some not, or just need serial monitoring with ultrasound. So, and then the musculoskeletal comorbidity is also a big thing, joint pain, many of you experience. And, but the other thing that I think is becoming more, draw more attention is actually osteoporosis, fractures. So the guideline recommended a DEXA scan, which is bone density scan, every 2 years if the patient have osteopenia, osteoporosis, which is sort of the density, we call it, that is discovered by the DEXA scan. But beyond that, I think acromegaly is not only about the bone size, it's probably also about the bone structure as well. So there's vertebral morphometry. You can get it on the CT scan or an X-ray of the thoracic spine or lumbar spine. So hopefully annually, particularly if patient have history of vertebral fracture, or decrease in the bone mineral density, kyphosis, which means a malformation or deformity of the spines, or symptoms of vertebral fractures, untreated hypogonadism, which is a risk, low estrogen, low testosterone can be seen as risk factors for the bone structure problem. And also, there's no biochemical control of acromegaly. So active disease, these need to be looked at as well. And there's also neurological comorbidities, right? So there's some people have neuropathies. As I mentioned earlier, many of them have carpal tunnel, but carpal tunnel is not the only neuropathy that patient will see. And sometimes I need to refer patient to neurology colleagues looking at the EMGs and nerve conduction study to better understand what's going on within the neurological system. And metabolic comorbidities, I mentioned earlier, so glucose metabolism. I keep mentioning about the sugars. So fasting blood sugar needs to be checked every 6 months, particularly in uncontrolled disease or during what we call, this is somatostatin receptor ligand or somatostatin analog therapy. As I mentioned earlier, if you're on pathology, pay more attention to your blood sugars and getting your A1C checked at least every 6 months or so if you're diabetic or pre-diabetic. So most of the diabetic patients that were not controlled or starting this medication, I tend to check them about every 3 months or so at the beginning of the therapy. Once they're stabilized, I know their levels, so we can then extend them to every 6 months. And then what about the other endocrine factors? As I mentioned earlier, there's other hormones from the pituitary that can be affected by acromegaly, the tumor, the surgery, and the radiation. So, for our men, we should check testosterone. There's SHBG is basically a protein that binds to testosterone, affecting the level of free testosterone that are available in our blood, and also prolactin level, because prolactin and also decrease or lower the testosterone production. You should check it annually, or consider checking it if the patient having symptoms. Now, the growth hormone sometimes can affect the SHBG, can increase the SHBG level. So if you're, I oftentimes do checking something called free testosterone, which is the unbound testosterone, because about 95% of our testosterone in the blood are bound to proteins. The free testosterone is about 2 to 5%. These are the active form of testosterone. And in women, we tend to check LH, FSH, estradiol, which is the main form of estrogen, and also prolactin level, just as important as in male. And check it annually in premenopausal women with menstrual irregularity or dysfunction, or and when pregnancy is desired. So we can try to fix this problem if we can before a attempt for conception. Free T4 level, this is very key because if you're seeing some endocrinology, they only check TSH, or primary care only check TSH. It is very important. However, patients with acromegaly, big tumor, are at risk of something we call central hypothyroidism, right? So in those cases, TSH is not a good marker for your thyroid function. Free T4 is. So, and sometimes we had to educate the primary care physician to check not only the TSH, but also check free T4, and using the free T4 mostly as a marker for the thyroid function. And also the cortisol levels. So I listed here at 8 and 9 a.m. as member at the very beginning of my talk. Cortisol is another hormone that demonstrated very strong diurnal rhythm. So they peak at 8 and 9 a.m. So the cortisol is a very, very important hormone. It's our stress hormone, but also I call it survival hormone. So this needs to be checked. If the central adrenal insufficient, meaning that if the ACTH producing cells, which drive the cortisol production, is compromised because of all the things I mentioned earlier, and then we can do something called colchicine stimulus test to confirm the diagnosis. So this is actually a fairly easy test to do in the clinic. My nurse can just do it. You get a baseline blood draw around 8, and then you get an injection called colchicine. An hour later, you get another blood draw for cortisol. That will either rule in or rule out the diagnosis of adrenal insufficiency, which is, among all this is probably the most important thing I need to study first, because this is the most vital hormone among all. I think the other thing I didn't put up here, there's also some needs for psychology and psychiatry support. A lot of people with acromegaly may have, the brain fog, they have depression, anxiety. I think there's also some unmet needs in that area that need to be taken care of. I think with that, I'll end my talk, and I'd like to take some questions. Thank you. Yes, Jane.
How do if we can get people to come to the microphone so that the people online can also hear.
Okay.
Okay, thank you.
How do the 3-month injections and the 6-month injections compare?
We don't have the 6-month injection.
We did before, though.
6 month?
Yeah, we did a trial with that before.
Oh,
there was an implant. In
oh,
the
yeah, yes,
upper
that's
arm.
not injection, it's implant. So
It's not an injection, I'm sorry.
yeah. Right now, we don't have the data for this one. At least that's why it's not commercialized.
Okay.
But for the 3 months I mentioned earlier, that's I think that's in enrollment actually. We may be actually one of the sites to do that study with the 3 months injection. But I don't think that actually there is not even a phase 2 trial yet, meaning that they're not on the human patient study on every 3-month injection yet at this point. But I believe that the companies who had this product is trying to start the study and enrolling patients. So stay tuned. Very good question. Yeah.
Thank you.
Yeah. Any other questions? Okay. There you go.
So we have a question from Zoom from Libby.
Okay.
Can elevated IGF-1 levels cause issues with reabsorption of CSF in the brain, resulting in intracranial hypertension?
That's a very good question. So people with acromegaly tend to have a little bit elevated intracranial pressures. So that, technically speaking or theoretically speaking, that can happen. So, but, this is going to be a really hard thing to begin to study because you have to measure the intracranial pressure in a way and try to define the disease, although you sometimes can use MRI to give you a hint about what's going on here. But I think at this point, I'm not aware a clinical trial or a very well-designed clinical study looking at that specifically. But that's a good question. That's why I mentioned at the very beginning, there's so much about acromegaly we don't understand. I think we understand much less than what we should be.
Okay, and then we've got a question from Jeremy in the Philippines. Does diabetes, ketoacidosis, and GERD also associated, or is it also associated with acromegaly?
That's a very tricky question. I think I can view that in different ways. Now, a few years ago, there was a very well-designed paper published in New England Journal. So that paper looking at ketogenic diet, a very low-carb diet, and it turned out to be that actually helped patients with acromegaly. So that's one part of the story. So there's some patients, when they're on ketogenic diet, that does help with. But there's some sort of caveat in doing so. First of all, is diabetes. I know some of you have diabetes, maybe already taking the medication in a class called SGLT inhibitors. So like Invokana, Farxiga, or Jardiance. Now this is a class of medication on its own can put people at higher risk of what we call euglycemic diabetes ketoacidosis. So if you're on this drug, I'll caution to use eating the ketogenic diet because that may exacerbate the problem. And then what's confounding is these people tend to have normal blood sugars when they have the ketosis, different from the one that actually, the typical one we talk about, the type 1, when they have ketoacidosis, they have very high blood sugar. So those are the ones hard to detect, just by finger sticks. So that's actually one thing I really want to mention about. The other thing I also want to mention about is just diabetes alone, even without the class of medication called SGLT2, is that if your diabetes is pretty poorly controlled, I mean, if you have a very high level of growth hormone, because remember, growth hormone is what we call one of the 4 anti-insulin hormone. We call it chondroregular hormone. So in our body, there's only one hormone that drives sugar down, which is insulin. But there's 4 other hormones that actually drive sugar up to counteract the effect of insulin, and growth hormone is one of them. So, I guess if the diabetes is poorly controlled, on top of that, if the acromegaly is not well controlled, that does raise some risk of ketoacidosis. But remember, diabetes is chronic disease and acromegaly is chronic disease, so you probably have had that for a long time. And usually the ketosis, you can see in those when there's a triggering event. That's, for example, you got infected. And though that actually can trigger the development of ketosis.
Okay,
Very good question.
thank you, Jeremy. And another question from Libby. What is being done to try to diagnose acromegaly earlier in the disease process?
That's $1 million question. I think that will be the first unmet needs we need to address as a society, and both as the researchers and our patient advocate group. It's hard. I mean, I think what we had actually, I was talking with my colleagues, we're trying to see in the future if AI, which is the hot topic, can help us to diagnose in different realms, for example, facial recognition, or a pattern recognition, meaning that if you have electronic medical record system, if you have all these risk factors, should we think about acromegaly, and also if patients are diagnosed with pituitary tumor. And some patients, they're seeking help because, I have a headache, right? So you have MRI, and found have a tumor, pituitary tumor. And sometimes that can be missed. So if our system has, like alerting, hey, this patient has pituitary tumor that was accidentally found, we should check IGF-1 and growth hormone. So I hope in the near future, the neurotechnology can help us. This is a huge unmet need. I mean, if you think of that way, if you're delayed by 5 years, and what if your tumor is much smaller, then you could actually have a much better chance of getting cured if they were diagnosed much earlier.
Right.
So that's one of the things. Unfortunately, again, you hear a story where a patient come in, I have a patient who's very young, and as I mentioned earlier, he said he was in a family reunion, and when the doctor in their family group realized the features of the face doesn't look normal, but the close family members who are living with that patient don't realize, because that's a gradual change over time, right? So it's hard. I mean, I think raising awareness of the disease as a society, both the patient advocacy group and our Pituitary Endocrine Society, I think is really, we should put emphasis and try to diagnose our patient earlier. And then if there was diagnosed earlier, and the surgeon doing a great job, then we don't need to deal with the comorbidities. That's pretty much needed.
Right?
Yeah.
Excellent, thank you. This one's from Bert in Nebraska. Can you experience an adrenal insufficient episode or symptoms that the body corrects by itself without needing steroids?
Yeah, this is going to be a tough question. I think diagnosing adrenal insufficiency is very interesting. So you have to understand. So I teach my fellow and resident, when you diagnose adrenal insufficiency, right, you have to answer several questions. So number one, do you have adrenal insufficiency or not? So as I mentioned earlier, there are tests that help us to diagnose adrenal insufficiency. Then the second question is, where the problem? In other words, is the adrenal insufficiency come from direct damage to the adrenal gland or direct damage to the hypothalamus and pituitary? And the last question, which is very important to know, is why? Okay, if you have a tumor, you have surgery, radiation, and you have adrenal insufficiency from the pituitary, that does not necessarily mean that, that all these are the factors. Because, some patients, they were put on steroid after surgery, right? So that alone can cause adrenal insufficiency. Now, the good news is that if the adrenal insufficiency is caused by a prolonged use of steroid, that can, recover over time. That means you don't have to take steroids. So you have to let your doctor look at your story carefully. And for my patient, if there is a suspicion, I think, maybe the patient getting too much steroid, or not too much, patient getting steroid around surgery, maybe that's a cause of the adrenal insufficiency. I can retest them. I can start with the medication, very adrenal insufficient, and retest them later to see whether or not, whether what we call steroid treatment caused the problem over time. So it's a dynamic assessment. Yes? Okay, you?
Mm-hmm.
Okay, so my question is on the test for
Yeah.
adrenal. Is it possible that a person can get stressed before the test, and then that ups their cortisol level, so then the test is invalid? So say I feel like I've got adrenal insufficiency because when it gets really cold, I'm exhausted, or really hot, I can't tolerate it, or stressed, I'm really tired. I've had gamma knife radiation, so I'm just curious. But I've had the tests, but I get extremely stressed,
Okay.
and then my tests come back normal. So all my cortisol levels are normal, but I feel like I've had adrenal insufficiency.
I think that's actually an interesting question. So in my view, probably not. And the reason I say that, because the normal test we do, we give 250 microgram of cosyntropin that raises our ACTH level about at least 100-fold than we normally have in our blood, right? So the normal value that we see at this point is number of 18 microgram per deciliter. If yourself can do that, whatever means you do, and you're able to raise that level on your own to 18, then you're perfectly normal. You're doing a stress test on your own. You don't need us at that point.
Okay. So that means my body's naturally kicking in.
Exactly. That's a good sign.
Okay, good, thank you.
Yep. Yes.
Yeah, no, you guys can come and line up also, so don't,
Yeah, I have question. Yesterday we could not attend that mycapessa or oral octreotide meeting, but in your experience, I don't know how many patients you have treated with oral octreotide capsules versus Somavalt or pegvisimone, and how effective it is. Because if some patient is taking Somavalt injection for almost 20 years, which is daily injection, it's a lot more expensive. So I was wondering if you switch to mycapessa or oral octreotide, can it be done, or will that work as a monotherapy?
I think that's a good question. You're talking about switching therapy, and actually switching therapy not only in the same class, the different classes. That's the important question to ask. I think that's why I want to see the pathology, right? I want to see their previous history. Had they ever been, in your case, they're on pegvisimone, and then they're on daily injection for 20 years, and then whether or not I can switch to oral. But remember, one is dealing with the growth hormone receptor, and one is dealing with, somatostatin receptor in the pituitary gland, right? So, I have to go back and look at the history of whether the patient has had somatostatin analog, the first generation, and using that data to help. It could be worth a try, but I think it depends. If they had failed the first generation somatostatin analog at a pretty distant dose, then switching may not be a good idea because remember, they're the same molecule, just given differently. If they haven't been tried and there's indication the tumor is densely granulated, right, it's not very aggressive, that can be done. So I think it really boils down to the individual characteristics of their treatment history, their pathology. All does help us to make a decision whether it's worth a switch. And also try to predict the success rate of switch. We don't just switch for the purpose of switch. We switch because either the current is not working, or we switch because insurance, of course, in this environment, and also we switch because we think maybe the new one is better than the current one. So I think there are many reasons to switch. That's why I think I like the individual approach for acromegaly, because each individual patient, they're so different.
Right.
And there's so many scenarios. I'd like to spend time with them and try to discuss about what the options. So if you're one of my patients, you can see every time, especially when we're starting, or when I knew there's a medication come on board, I go over the list again from top to the bottom, like I mentioned earlier. So I give them the options of, see, these are the options, these are the pros and cons of each approach, and what do you think? I mean, most of the time it's a joint decision, of course limited by insurance, but it is what it is.
Yeah, but do you have any patients on that oral octreotide, which
Yeah, I do.
and then they do well?
Yeah, they are controlled at this point, yeah.
Yeah, I think this patient has taken sandostatin injection before the Somaward came into market, and that was not that effective, I think, so I'm not sure.
Yeah, so I think I encourage you, as Jill mentioned, talk to the doctor who treat the patient, have a detailed discussion about the thing you want, the thing you think may be effective, maybe helping you, and then go on with there. Yeah.
Okay, thank you very much.
Of course,
Yeah.
of course. Yes.
Hi. I heard you speak of encephaloma, I'm not sure how to say that,
Malaysia?
militia,
Okay.
with radiation. If you had a patient that had an MRI result that said patchy central punctine right corona radiata, how do I say that?
Yeah.
And left frontal periventricle white matter, T2 flare,
Okay.
hyperintensity is likely secondary to chronic white matter, microangiopathy, focal chordal encephalomalacia in the medial anterior left temporal lobe. Is that from radiation?
Well, this is unfortunately, I think it's very specific, it seems like, to a patient. I'm not a neurologist. I think this will be best addressed by a neurologist who's more specialized in this realm. And also you can talk to, if the patient already received radiation, I highly encourage you to talk to the radiation therapist or their doctor, radiation. So I think that's a very, very specific question. And as I said earlier, there are complications from the treatment. There's also comorbidities. A lot of times I ask my colleagues to help me to tackle those problems.
Okay.
But remember, we're not alone. Acromegaly is not just you, the surgeon, me. There's other doctors, right?
Right.
So the ophthalmologists help with the vision, right? And the radiologists help to read the images and things that go on.
When you said that word,
yeah.
that stuck out to me. So I wanted to see if that came from radiation.
I cannot answer those questions right now, but I think I encourage you to talk to your doctor about,
Right.
especially who is doing the radiation, and also a neurologist to deal with a specific matter.
Okay. Thank you.
Of course.
And thank you for everything else.
Oh,
I really
thank
enjoyed
you.
it.
Appreciate it. All righty then. Oh,
Okay, nope, sorry. Another question from Libby. What is the accuracy of the OGTT very early in the disease process of acromegaly?
so are you talking about before? I guess that's before surgery, right?
I think so, Libby. If you want to post, I can respond. But if you're speaking
Let's
about
just say
before,
if it's before surgery, I assume that, I think is
I would
this
assume.
is what we call confirmative testing. We utilize
before surgery.
before surgery, right? So we utilize this feature that the growth hormone is, suppressed by glucose when it's ingested in our body. So remember that, in classic cases where the patient have a known tumor and the growth hormone is very high, IGF very high, you probably don't need a oral glucose tolerance test to make the diagnosis. And what is most helpful in my scenario is I have patients where the levels are not very consistent, and actually it does happen in quite a few ways. There are some patients who have high level IGF-1 normal growth hormone and vice versa. So these are some diagnosis challenges even for experienced endocrinologists. So in those cases, an oral glucose test will definitely help us try to define the disease, define the suppressibility of growth hormone by the glucose to making the diagnosis. Pay attention again to the assay that's used, which is also a big unmet need in this field. Each assay have their own characteristics. It's hard to unify or harmonize them. And I hope one day we can harmonize them so we don't have to worry about the assay itself. Is it good? Last one, please.
Because there is so many people undiagnosed, is there any appetite for adding like an IGF-1 to regular testing? Like you get a colonoscopy at 40, could they possibly check that as well, and maybe we could catch some people early?
That's a very good question. I can use one analogy, is that many years ago, the chemistry panel does not include calcium. That was many years ago. And later on, that was incorporated into the testing, and we began to see more patients with something called hypercalcemia, hyperparathyroidism. Now, for screening tests, that has, definitely have medical needs for that. The big question is, and then for someone to be using a screening test, for example, mammogram, colonoscopy, there are many factors in that. For example, the prevalence of the disease, is the disease very prevalent? And then what about the economy in terms of screening tests? And then come on that, what do we do? Is there any cure or treatment for that? There's many factors that come in role in trying to define a screening test. As I mentioned earlier, I think the IGF-1 level should be checked in a high risk, what I consider a high risk group, especially, as an endocrinologist, if you see there's something wrong there, probably there is something wrong there, and you can do that. In the general population, though, I think that may be a hard, to do, because remember that every year, 1 out of 100,000 patients have that. I mean, would you say the other, 99,999 patients will want to have IGF-1 level checked? They're probably not.
Okay.
But that's a good question. I think hopefully, as I mentioned earlier, the AI can help us to learn more about this with pattern recognition. It's not only about the facial pattern, their hands and feet, and also I think the chart, electronic medical record system, I hope at some point we can utilize that to give us more information.
I have another question. With the high risk, comorbid risk of cardiomyopathy, is there any indication for patients to advocate to have echocardiograms regularly?
Very good question. I think that's, I personally starting to, or already doing that is I got baseline echocardiogram. Now, as I mentioned earlier on the comorbidity, if the patient is well controlled, right, then they may not need it annually. If they are, either they have cardiomyopathy or they're not well controlled, I definitely want to follow them up with more echocardiogram. If they do have cardiomyopathy, I already send them to cardiology. So those are, I think, the very key points. So with all the comorbidities, what I'm starting to do, I try to gather my baseline as much as I can. But also, I have to say that some patients are swamped with information, right? So they got diagnosed, have a brain tumor, they're going to see the surgeon, and then there's other things that I plan for them, like a cardiogram, maybe thyroid ultrasound, bone density scan, sleep study. And this is too much. But the good news is that some of the baseline we can wait after. It won't change very rapidly. If you have cardiomyopathy or something, it won't change overnight, right? But these are the key things. I try to prioritize things. So definitely if they have symptoms that concern with the heart, I'll definitely do that because that affects surgery, anesthesia, and go forward, right? The bone density, if they don't have time before surgery, we can wait until after surgery. And then I prioritize our drug. And also I prioritize looking at other hormones. Remember, I would never want to miss the diagnosis of adrenal insufficiency before surgery.
Yes.
Yeah.
Thank you so much.
Yep.
Final question.
Yeah.
Okay, yeah, sorry.
Yeah.
What if you already have, in conjunction with acromegaly, liver problems? Or if you have, because if you don't get a surgical cure, you could be taking, in my example, meds for like 60 years. But if you already have problems with your liver,
That's a good question. I think there are several aspects of looking at. Number one is you have a liver problems, is that because of acromegaly per se, or there's something else that causing the liver problem? So you want to look for the cause of it, right? So I sometimes actually enlist help from hepatologists to help me to define, let's say if they don't find any source of that, I think we may contribute to the metabolic derangement that is a result of the acromegaly, and I try my best to control the acromegaly. In the meantime, I also be a little careful about the medication that we're going to use for treating acromegaly, as I mentioned earlier. And of all the meds we know here, pegvisimone has been shown to cause some liver abnormalities, even at a small percentage. The quoted percentage around 3 to 4%. So if you're careful when you use it, doesn't mean you can't use it. You have to use it, with close monitoring. And also there may be some other drugs that can also help with cirrhosis of the liver or non-alcoholic fatty liver disease, we call it NFLD. And then these are also sometimes I like to enroll the hepatologist into the big spectrum of team and try to help define and treat it.
Okay.
Very good question.
thank you.
I think I'm good. Thank you, everyone.